where did you say the link was going to be on the for the recording?
Within the Teams platform, you should see it. Either way, it will be uploaded to the Vermont Health Learn platform as well following the meeting.
Is it possible to get the link to that?
Okay, Dr. Ward, we're right about noon.
Well, welcome everyone. This is Norman Ward speaking. I'm the Chief Medical Officer for OneCare Vermont, and I want to welcome you to our asthma and COPD collaborative session today on asthma and COPD action plans. We're very excited about today's presentation from Dr. Baalachandran from the UVM Medical Center. We have quite a number of practices involved in our collaborative, and those practices will be invited to stay on at 1 o'clock for some additional time with our presenter and some interactions about the collaborative process itself. So, Tanya, could we go ahead and advance? So you will be muted, but also be cognizant of muting yourself as well so that we have a good conference experience. The QR code for claiming credit is here. You can literally take a picture of it right off your computer screen and get that link for claiming credit, or you can harvest that QR code later when you have the slides in hand. Next slide. So I'm going to keep my introductory comments very short. Next slide. So I have not had the pleasure of personally meeting Dr. Baalachandran, but I am so pleased that you've agreed to present to us today. He is a pulmonologist and intensivist at the medical center, involved with all of the full spectrum of pulmonary care, including bronchoscopy and endobronchial ultrasound. Has a broad array of clinical interests around pulmonary care, but also, in his bio, clearly is interested in the improving the quality of care and having patient-centered care. And there probably are fewer examples of patient-centered care in terms of creating action plans that can help people take charge of their illnesses, both asthma and COPD, and have a well thought out approach to addressing decompensation for their conditions. He's an assistant professor at the Larner College of Medicine, and his research interests include biomarkers in sepsis and offering that as a tool in facilitating early diagnosis. So, Tanya, I think we have one more slide here. Are you sharing the slide deck, Tanya? There we go. Okay. So our learning objectives today are to analyze and understand the components of action plans, to look at the effects on outcomes for the care of COPD and asthma, and also to understand and explore the limitations and barriers to their use. So without further ado, Dr. Baalachandran, the floor is yours. Thank you so much.
Can you hear me? Tanya,
Yes.
I'm going to share my screen.
Okay.
Can you hear?
Yes.
Okay. Dr. Watt, thank you so much for such a kind introduction. It's an honor to be here today to present to such a enthusiastic crowd of physicians. It's also nice to be engaged in an educational, interactive session that is not related to COVID. For the past 6 months, all our lives, academic and otherwise, has been all about that. So my topic for today is action plan for COPD and asthma. And like Dr. Ward already mentioned, the main goal of today is to see what is the effect of this action plan on the outcomes of these diseases. We'll also go into what are the components of the action plan. I will also try to delineate the limitations and disadvantages of using the action plan so that we can make an informed decision while implementing it in the clinic. This is a very vast topic. It has a lot of aspects to it. And I think many of you are probably already familiar with most of it. So the way I've approached this topic is I've tried to highlight important clinical points, which I think are very important in implementing this in the clinic. So that's the angle from which I'm approaching this topic. And I'm going to warn you that most of this talk is going to be about action plan and COPD. Most of those principles, I think, apply to asthma also. I have a few slides explaining the differences in asthma and some of the unique aspects of action plan in asthma. But most of this talk, I'm going to talk about action plan with reference to COPD. So I can't overemphasize that COPD is a significant cause of preventable worldwide morbidity and mortality. Currently, it's the 4th leading cause of death. It is the #1 cause of hospital admissions. It's also a big burden on our healthcare expenditure. It's also affecting people's life in a very major way. 1 in 7 people with COPD report that they have stopped working permanently because of their disease. That's not all. The COPD, the GOLD report recently, and also the WHO report indicate that this problem is going to get worse in the coming years. We expect that COPD is going to become the 3rd leading cause of death by 2030, and also will become the 7th leading cause of disability adjusted life years lost by 2030. So it is very important that we have to understand every aspect of this disease and try to prevent that from happening in 2013. So before going into action plan, I want to take a few minutes to discuss about what is an exacerbation. What actually is a COPD exacerbation? So the GOLD initiative, the Global Initiative for Obstructive Lung Disease, actually mentions it in a very nice way. So they say it's characterized by a worsening of the patient's respiratory symptoms that is beyond normal day-to-day variation and leads to a change in medication. So I think there are 2 aspects to this. One is change in respiratory symptoms, which could be breathing, cough, sputum, change in color of the sputum, quantity, etc. And the other is change in medication. The thing I want to highlight here is when understanding what an exacerbation is, we have to understand that it's not just taking prednisone and antibiotics, but change in any medication. So even if there's any change in the inhaled therapy or the nebulized medications that the patients are taking, that does constitute for an exacerbation. It is any change from the normal day-to-day variation. And why is it important? Why are we all bothered about exacerbation? So one of the important goals in a COPD patient is to prevent an exacerbation. We do not want our COPD patients to have exacerbations. And the reason for that is with every exacerbation, the patient is losing ground. They're losing some lung function. There are multiple studies that are showing that people who have had even one exacerbation, subsequently have poorer health status, accelerated decline in FEV1, and a worsening of their quality of life indicators. We also know from multiple studies that in the year after a hospital admission for an exacerbation, there is increased chance of mortality in the patients. So the people who have had exacerbations, they become very high risk patients with very poor outcomes. So I think it's very important for us to know about an exacerbation and try to treat it appropriately and also prevent future exacerbations. Now, with reference to this talk about action plan, I want to highlight one aspect. If a patient has an exacerbation at home and does not come to the ER or does not get hospitalized, doesn't seek medical care, that is not the same as not having an exacerbation. So I think when we implement the action plan, we have to be very clear about defining these goals. We have to understand that preventing exacerbations, which is defined as a change in symptoms, which is beyond what is normal day-to-day variation. So if we have that is what is an exacerbation. So preventing an exacerbation is not the same as preventing in a hospital or an ER visit. A patient can have an exacerbation which is not severe enough for them to seek medical care. And that is also important, and we'll see why. So where does action plan fall in the myriad of therapeutic options available for COPD? So this is a image from the GOLD guidelines, the pocket guide that is available, and they place it high up there, along with smoking cessation, vaccination, initial pharmacological management, inhaler technique. Written action plan is one of the things that they're suggesting that we do right away, immediately after diagnosis. So it's not just these guidelines. Many of the other guidelines also mention that immediately after diagnosis, when we first see the patient, every COPD patient should have a written action plan. So why is so much importance placed on creating an action plan? So like I already mentioned, there is a lot of unreported exacerbations.
Doing
and
well.
These
Overall period.
These unreported exacerbations are important because they still impact health status. So we know from studies that this loss of lung function, worsening of quality of life, and increased risk of future exacerbations and mortality does not apply just to hospital admissions due to COPD exacerbations, but also it is related to the unreported exacerbations, the mild ones that the patient is having at home. And the other reason why we have to have an action plan is late treatment of exacerbation is associated with slow recovery, longer hospital stay, worse quality of life, and increased ICU admissions, increased chance of ventilation, and increased healthcare utilization. So that is why it's important we have an action plan, so that we're able to identify and treat the mild exacerbations that patients might be having at home, and also treat them early so that they don't present with very severe symptoms. So what is an action plan? So an action plan includes interventions designed to allow patients to recognize and initiate early treatment for exacerbation. So there are two aspects to it. One is that the patient should know to recognize the exacerbation, and the second aspect is that the patient should know how to initiate treatment and what to do. So it has to be in a structured way. There should be a certain skeleton for us to design this plan for the patient, but it cannot be rigid. It has to be personalized to each patient. Each COPD patient is different, and the structure should be individualized to each patient based on their presentation, their symptom phenotype, how they respond to different medications, their other comorbidities, etc. And of course, it's multi-component. It's not just taking medications. It has multiple other components to it. And what is the main goal? I think the main reason, reason why we should implement this action plan is it is a very important, very good way, effective way to engage the patient in their disease. COPD is a chronic progressive disease, and it's very important that the patient learns about their disease and engages with the physician team to improve their quality of life. So I think the action plan is a very good way to motivate the patient, to engage them in their care, and to support them in learning about their disease and how they can modify their behavior to improve their disease outcome. So this table summarizes some of the studies that have looked at implementation of an action plan. And I think this summarizes some of the components of the action plan. If you look at the first column, this is talking about an individualized action plan versus a standard action plan. You see, only one study looked at a standard written action plan. Most of the others used which showed any kind of improvement and outcome used an individualized action plan. So I think it's very important that an action plan is not just created as a knee-jerk phenomenon or as part of a checklist for COPD management, but we have to make sure it is individualized to the patient in front of us. Now, there are two kinds of action plan. One is the written action plan and the oral action plan. Most of the studies looked at written action plan. One study also looked at oral action plan, which also showed some improvement on outcome. And frankly, I think practically this is what is implemented more often than a written action plan. Most patients I've seen have had some discussion with their physician or provider about what to do in the case of an exacerbation, but not many have a written action plan in place. Whether oral action plan is inferior to written action plan, we don't know. We don't have any head-to-head comparison. But most of the studies which look at outcomes of COPD did look at written action plans for COPD. Now, the other aspect is what kind of support studies give in the follow-up period after the action plan was created. So many of studies had a nurse or a respiratory therapist call the patient a few months after the action plan was created to reinforce, to reorient, to re-educate the patients about the action plan, because it is a continuum, and the action plan is not static, it's not set in stone. It may have to be modified based on the patient's clinical course. So many of the studies also involved following up with the patient over a phone call after the action plan was created. I'm not sure how much this is feasible in our practice. I definitely don't do it in my pulmonary clinic, but this is something to think about if we were to implement it in the right way. And the other next column is talking about how these studies implemented education sessions. So it was not just creating an action plan. All the effect on outcomes were proven only when these action plans were combined with a brief education session. And the education session lasted from anything from a 1 hour group session to a private session with their physician or nurse or educator to a 1.5 hour group session. And they were also given written material or printed material, education material. So that is why I think the action plan is a comprehensive program. It's not an individual intervention. It's a comprehensive program. It is a method by which we can motivate the patient to engage in their disease, participate more in the care, and also learn about their disease more. And it becomes a platform for us to provide the patient with as much education as possible. So though the goal of these studies was to look at the effect of action plan on COPD outcomes, most of them did end up involving follow-up through telephone calls, short education sessions, and also giving patients some education material. I'm not sure how much of this is it's possible to implement in our busy clinical practice, but I think definitely one thing I always do is when I create an action plan, I try to have the first time I see a patient and create an action plan, I try to have a 3-month follow-up to sort of reinforce and get to know the patient better and give an opportunity for the patient to ask more questions about the action plan. And we try to give as much printed material as possible. Up to date is a great resource. Gold itself, the Gold's website itself has a lot of resources on COPD. The American Lung Association has a lot of resources online for COPD patients. So I think these are good resources to get printed material and education material for patients. So I think we should always club the action plan with these intentions also. So this is a screenshot of the COPD navigator in Epic. I'm not sure how many physicians here use Epic. You may be using some other healthcare information system, but Epic has a COPD navigator, and the COPD navigator has a lot of parts to it. The MMRC grade dyspnea the patient has, the number of exacerbations they've had, and the medications they're on, the medications we are prescribing, etc. And it also has a component for creating an action plan for its patients. So if you see, you tell them which path to take if they're having difficulty breathing or a change in their symptoms, whether they should call us or whether they should automatically implement the action plan or whether they need to be seen in person every time they have change in symptoms. And it also tells them what to do if they have to initiate the action plan. Usually the action plan consists of 3 main components. One is rescue inhaled or nebulized medications, bronchodilators mainly. So usually we use albuterol or Dioneb, and then whether they have to take steroids or not and how much they should take. And the third aspect is the antibiotics. And it is also very important to give them red flag symptoms and say, hey, these are the red flags. If you have any of these, do not hesitate to go to the ER. Also, we have to tell them if they're not improving, they should definitely either come to the physician's office or PCP's office or go to the ER. If you see here, there is to a COPD action plan letter. So once we fill this and create a letter, it automatically generates a COPD action plan, which the patient can take home. If they have home health, we also fax it to their home health nurse who can have it, and she'll know what to, he or she will know what to do in case the patient has an exacerbation. So the main things the action plan letter has is, one, it lists all their maintenance medication. Then it also gives them a list of symptoms that they should watch out for and sort of give them a idea about how to recognize an exacerbation and also how to classify the exacerbation as mild, moderate, and severe. And depending on the severity of the exacerbation, they're given recommendations on intervention. The letter tells them whether to take steroids, antibiotics, whether both, whether they should try some inhaled or nebulized bronchodilators before trying the steroids. There are some who like to double the dose of their maintenance inhaler, like take 4 puffs of Symbicort or take 4 puffs of Fluent. There's no data for this, but some patients like it and they do that too. And of course, we have to tell them when to contact their physician. And we have to also give them prescriptions for that so that they have these medications at home and know when to use it. So this is an example of the COPD action letter that we create. So this screen does not show the mild dose or the stable state, which is usually the green zone. So usually the patient is in the green zone, there is nothing to do. If they're in the yellow zone, they have to take some relief medications, and in the red zone, they usually seek medical care, either go to the ER or urgent care. So I also want to highlight some of the non-pharmacological interventions that can be done as part of the COPD action plan, which are usually not given that much importance. So one is using oxygen. Many COPD patients who are frequent exacerbators are also on oxygen. And increasing the flow rate of the oxygen sometimes is a very, very effective way of countering the breathing difficulty that they have. So there are a lot of factors that play into the decision that a patient makes to go to the ER. Most of these patients are very dyspneic at baseline. So it's not just that they are having dyspnea or more cough that makes them come. What happens is when they have an exacerbation, they might have increased inflammation, more bronchoconstriction, more mucus production depending on their phenotype, and they might have a mild worsening of their symptoms. And not getting enough air, that air hunger itself causes them to become very anxious. And this anxiety makes them breathe very fast. And the tachypnea itself worsens the air trapping and the obstruction because the COPD patients are prone for hyperventilation. I'm sorry, air trapping and hyperinflation. So they are. If you have seen the respiratory therapist coach the COPD patients, one of the important things that is taught to them is consciously try to breathe slowly and breathe with pursed lips and make sure that they breathe out for a long time. And this helps in emptying the lungs and decreasing the hyperinflation. So during an exacerbation, anxiety plays a very important role, and the air hunger makes them very anxious, and they start breathing very fast, which worsens their symptoms, and they end up going to the ER. So sometimes all they need is a reorientation and sort of slowing down their breathing, making sure they're breathing out for a long time. And I think the increasing the oxygen flow rate helps them to sort of go through that, slow down their breathing and break that cycle of dynamic hyperinflation. So I think if they have oxygen at home, that's definitely something we can ask them to try. So one calls that we've been getting in our clinic a lot after this COVID is a patient's calling to say that their pulse oximetry reading is low. I think many of them went online and got pulse oximeters during the COVID time, and they have been constantly measuring, keeping a log of their SpO2, and they know how much it is usually, and they'll call us saying the SpO2 is low. So again, this needs further investigation. We probably have to talk to the patient and figure out whether this is just like a normal variation, or is it associated with any other symptoms suggestive of an exacerbation, and whether it needs initiation of the action plan. The other thing I want to highlight, which is becoming increasingly popular, is non-invasive ventilation at home. Many of the patients with COPD also have sleep apnea, and they use CPAP at home. Some of them have obesity hyperventilation, and they're on BiPAP at home. And non-invasive ventilation is becoming popular for COPD patients with chronic hypercapnic respiratory failure. Now at the University of Vermont Medical Center, we have a non-invasive ventilation clinic. We have an NIV clinic. I think it's once a month under the leadership of Dr. Dixon. So there is definitely a group of patients, an increasing group of patients who have BiPAP at home. And I have tried in the past to use this as part of the action plan. So the patients have to be selected very carefully, patients with adequate healthcare literacy and who know, who've had COPD for a long time, know when they get their exacerbations, are pretty familiar with how to use it, have some help at home, have a family support. I think these patients are very good candidates where if they feel like they're having a bad day and their symptoms are getting worse and the nebulization is not helping, to advise them to use the BiPAP to give them some symptomatic relief. And of course, the other thing that it really does, like I already mentioned, is that it breaks that cycle of COPD exacerbation, air hunger, tachypnea, dynamic hyperinflation, worsening COPD, the worsening symptoms, and ER visit and hospitalization. So it breaks that cycle and sort of prevents that dynamic hyperinflation from happening. So I think that is another tool which we can use as part of our action. So what is the effect of these action plans? Do we have any evidence that these are actually useful? So there was a Cochrane analysis which looked at all the studies on action plan, and this was published in 2016. And the only, I shouldn't say only, the main indicator which showed a significant difference was the hospitalization and e-visits over a 12-month period. So patients who had an action plan created and also had a phone follow-up had a decreased number of hospitalization and ED visits in a 12-month period compared to patients with usual care. And they determined the number needed to treat was 19. That is, if for every 19 patients for action plan was created and a phone follow-up was conducted, one ER visit or hospitalization was prevented. They did not find any effect on mortality. The effect on hospitalizations alone was also variable. Some studies showed a trend towards benefit, but it was not statistically significant. The same effect was seen for ED visits alone. So if you look at the amount of drugs that these patients took, I guess it's not surprising that the patients who had an action plan had took a increased total dose of steroids in 1 year, and they were also on steroids for a longer period of time. Now, this has to be, we have to read this very carefully, because we don't know, of course, there was no difference in mortality, but whether being on these increased dose of prednisone created any long-term problems for these patients, whether they had more steroid-induced side effects, whether this was because we know that increased use of steroids is associated with many problems like osteoporosis and fractures, etc., and ulcers. So we don't know. I don't think any side effect or safety profile has been conducted on this, but this is something we have to be wary of. And in some patients, we just don't have a choice because their disease is so bad. We just have to treat them with steroids frequently. But when we create an action plan, we have to be mindful of the fact that these patients have the risk of taking a higher dose of prednisone over 12 months, which necessarily doesn't improve their mortality. So these patients are also prone to take more courses of antibiotics. They are prone to be on antibiotics for a longer, for more days in a 12-month period. And this is also important to know. One example that comes to mind is patients with heart disease. If they have COPD and they are given azithromycin as a part of their action plan, it puts them at a higher risk for QTC prolongation and arrhythmias. So we have to be mindful of these facts. So we have to weigh the pros against the benefits. I mean, the risks against the benefits. So what is the effect on quality of life? The result was not very convincing. There was definitely a trend towards a better respiratory related quality of life, but it really did not meet statistical significance, or the difference was not clinically meaningful. For example, SGRQ, the St. John's Respiratory Questionnaire, is one of the popular ones used in any of the studies. And for a minimum clinically important difference, they say the intervention should cause a decrease in the score by at least 4 units. And I think these studies showed a decrease by 2.82. So whether this is really that makes a big difference in the patient's quality of life, we don't know. The same applies to the HAT scale, which is anxiety and depression scale. It did show a trend towards lesser depression and anxiety in these patients, but it really did not reach clinical significance. And I think this is important to note, because when we create an action plan, I think it's intuitive to think that it empowers the patient. They should be less worried about exacerbations because they have the medications in their hand and then take it before their breathing gets worse. But ultimately, it did not result in a big improvement in their quality of life or anxiety. So one convincing advantage that the study showed was consistently the study shows that there was lower cost per patient for hospital admissions, and there was also lower cost of the ED visits. So definitely educating the patient to identify the exacerbations early and initiating treatment early, I think prevents the exacerbation from becoming severe. It prevents the total number of ER plus hospitalized hospital visits over a 12-month period, which ultimately results in decreased cost of hospitalization per patient and cost of the ED visit. So what are the main problems that we face? So it is a little discouraging that there was no effect on hospitalization itself, which means that the action plan does not alter the clinical course of the COPD. COPD is a chronic progressive disease, and the action plan is going to empower the patient, maybe engage the patient, maybe give them more options, maybe, but it's not going to affect the severity of the, if a patient is prone to develop severe COPD exacerbation, initiating the action plan or having an action plan is not going to change that. It was also a little discouraging to the community that it didn't have a big effect on the quality of life, because you would think it would. But personally, I think if in the right kind of patient, I think it plays a big role. Very often you have patients who come to us and say, hey, I was feeling really low for like a couple of days. It was over the weekend. I tried to reach the office. I was not able to get anything. And I went to an urgent care. They wouldn't give me any prednisone. They just gave me nebulized bronchodilators and sent me home. If only I had the prednisone, I think we could have prevented this from becoming very severe. So I think those kind of patients will really benefit from the action plan and having those prescriptions at home. So I think the right patient selection will probably definitely make impact on the quality of life of the patient. The other important worry that we all have is misdiagnosis. So when there is a change in symptoms in a COPD patient, it could be a number of things. It could be pulmonary edema, it could be MI, it could be pneumothorax. Many of these patients have emphysema and blebs. So they could have, bleb could have ruptured and caused pneumothorax, tension pneumothorax. So it's not always COPD exacerbation, and that is always a potential diagnosis. That's why I think it's important to tell the patient to come to the ER if the symptoms are not getting better right away. And also, I think that's why patient selection is very important. I usually take a few visits to tell the patient, hey, you don't have to call me. This is automatic. If you have these symptoms, just take it. Because it takes me a few visits to figure out what the healthcare literacy of the patient is, what their understanding is, how good they are with their medications. So I think it takes a few visits. I always hesitate to initiate an automatic action plan the first time I see a patient. The other thing is resources. So all these had a dedicated nurse navigator or a respiratory therapist who was working with these patients, educating, constantly reinforcing them, answering questions. Whether this is possible for us to do in our clinic practice, I'm not sure. So I think that is definitely something to think about. I think a lot of physicians and providers do create oral action plans where they tell the patient what to do if they have a exacerbation, but creating a written action plan and implementing it may not be possible for all COPD patients, but the frequent exacerbators and patients with severe symptoms, I think definitely we should take the time to initiate that. So the increased use of medications, like I already mentioned, is definitely a concern. These steroids and antibiotics come with a price. They all have side effects, so that is something to remember. And the other worry is delayed presentation to the hospital. Sometimes patients may have a false sense of reassurance because they have these medications at home and they not come to the ER when they have to. And that is why it requires a certain relationship to be established between the physician, provider, and the patient before implementing it as an automatic action plan. We already spoke about the health literacy of the patient being a major factor in implementing these sometimes. So most of the aspects that we spoke about in terms of components of action plan is pretty similar to COPD, and it's the same in COPD and asthma. But there's one new development which I think is good to know is the smart therapy. So before the thinking was that we have a maintenance inhaled corticosteroid for asthma and use short-acting bronchodilator like albuterol for as needed as an as-needed medication for breakthrough symptoms. But now even the GINA guidelines is recommending that we use a formoterol containing combination inhaler of ICS and LABA, which is Symbicort. So you can use that as a maintenance medication and as an as-needed medication. So if you look at the latest GINA guidelines, they recommend starting Symbicort as needed in step 1. And as you go, especially in step 3 and 4, use Symbicort as a maintenance medication and as a reliever medication. So they can take up to 12 puffs per day. So use the same medication, which leads to less confusion, and it's also more economical for the patient. They do not recommend increasing the dose or using as needed inhaled corticosteroid alone, but there is some evidence that the combination inhaler like Symbicort can be used. We don't have a similar evidence for the other combination inhalers like Breo, Ellipta, or Advair, which contain an inhaled corticosteroid and a LABA, but we do have evidence for Symbicort, which is a formoterol containing combination inhaler. Of course, most of these patients will have prednisone as part of their action plans. Some of them also need antibiotics, and this is mostly the patients who've had long-standing asthma and have a fixed obstruction, so they have COPD in their PFT and sort of behave like COPD, and they have to be identified carefully. And as we know, azithromycin also has some anti-inflammatory effect, which might help them. And this is another Cochrane analysis that was done for implementation of action plan in asthma patients, and frankly, it's not very encouraging. It really didn't change any of the outcomes. There was maybe some trend, a trend towards improvement in the quality of life indicators, but it really didn't reach clinical significance. One interesting finding of this analysis was there was a trend toward, though the quality of evidence was very low, there was a trend towards slightly higher respiratory related deaths in the asthma patients who received the action plan. This was interesting, but it was very low quality of evidence. So it doesn't mean that we shouldn't create action plan for these patients, but it's just that we have to remember that it is not foolproof. So to conclude, I just want to say that an action plan is not a magic bullet. It is not going to change the clinical course in any way. It does not have any effect on mortality. So it should be implemented with caution. We should also consider the risk for side effects in these patients. If they have cardiac disease, if they already have osteoporosis, if they have any stomach ulcers, I think these all should be considered before implementing the action plan. So it's not without danger. I think every COPD patient should have an action plan, oral or written. Every frequent exacerbator who has frequent ER visits or hospitalization should have a written action plan. But I think the most important thing is to use the action plan to engage the patient with the disease. So we have to remember the action plan is not a way to make sure that the patient doesn't come to the ER or the hospital, but use it as a method to engage the patient in their disease. So it is going to require frequent visits to a provider, frequent discussions with the patient about this, and also understand the phenotype of the patient. So that is why it's very important that the action plan should be personalized to the patient. It's beyond the scope of this topic, but there are some patients who will benefit only from prednisone. There are some patients who will benefit only from antibiotics. Some are of the bronchiectasis phenotype. Some are of the asthma phenotype. So it's very important for us to understand the phenotype of the COPD patient or the asthma patient and implement action plans accordingly. And also understand the disease course of the patient. Somebody who's been very mildly symptomatic, had one exacerbation because of a pneumonia, and is doing well after, may not need an automatic COPD action plan. Somebody who's having 3 or 4 ER visits every year, who has severe disease, who will probably benefit from an action plan. So I think patient selection is very, very important in implementing this. And it is very important once the action plan is created to review with the patient and make changes at frequent intervals. So like I said, the way I use it is I don't create action plan for all the COPD patients. We have the patients who've had exacerbations in the past, what we call as group B or D. I definitely try to create an action plan, especially if the patient has a home health care being provided. Then I would definitely create a written action plan, send it to their home health nurse. So I think it's important to use the action plan as a platform, as a program, rather than one thing that you have to check in the list of things that you have to do for COPD patients. And I think that is the end of my presentation, and I'll be very happy to take questions.
So, Ram, this is Norm Ward calling. Thank you so much for your presentation. Do you want to bring up the chat box? There are some questions there that you might want to perhaps read and comment on. Maybe start at the bottom and work up, something like that.
I'm not sure if I'm seeing the chat box. Give me 1 second. I'm gonna.
It's next to the button where it looks like two people on the top part of your.
Yeah, I found it. I found
okay,
it. So the first question is from Dr. Ward. And the question is, how do we think telemedicine assessment of COPD asthma exacerbations will augment, improve the outcomes with action plan utilization? I think the telemedicine is already playing a very, very big role in the management of the COPD patients. So I think that's why it's very important when we create an action plan to define what our goal is. That's what I try to ask myself every time I do it. Why am I doing this action plan? I don't think creating the action plan is going to have any effect on the number of exacerbations the patient has. Like those studies showed, they might end up using, the people with action plan use more steroids. They're on steroids for more number of days. So I don't think it's going to make a difference to the number of exacerbations. I don't think it's going to make a difference to the mortality, but it might make a difference in healthcare utilization. So they might come to the ER and hospital less, which I think is an important outcome. So those are the kind of patients I try to implement the action plan, and definitely telemedicine is going to play a very, very important role, and we should make use of it. Like I said, whenever I create an action, I try to follow up with the patient, and now I have the luxury of making that a telemedicine or a televideo visit. So thanks for that question. So the next question is, many times patient feels much better, but their numbers do not verify this. Why isn't this included in the quality of life assessment? This is from Barbara Black. Can you clarify that question? What numbers are you referring to?
When they're collecting data after they have used this and they are trying to come up with does it work or does it not work? Yeah. Usually the patient, even though they feel better, they are functioning better, and everything about them seems to be better. They're in a better mood. Their disposition has changed, yet their numbers don't verify this. And they haven't got higher oxygen numbers. And this doesn't show up anywhere in the data that's produced.
Yeah, that's tough. It's frankly, exactly like you mentioned, many of the patients for whom I have action plans, they love it. Like you said, they feel more empowered. They feel because every time they have to call somebody and beg for that prednisone, it just makes things worse for them. They're already not in a very good place with the breathing. So it makes them feel empowered, and they are very, very happy with it. But it doesn't, the studies don't show it. And I think one of the aspects for that is all these scores, especially the St. George's respiratory questionnaire, which they use in most studies, it has I think 30 or 50 items in it. So it assesses a lot of things. And in fact, in one of the studies, they have gone through every aspect. So the SGRQ, the St. John's Respiratory Questionnaire, has different components to it. One is a psychological component, one is a breathing component, a distance component, then there's an overall component. So the intervention didn't actually make a difference to any of the components. And I think In one of them, which looked at quality of life over a 12-month period, there was an improvement. There was a significant difference, and the people with action plan had a better number, but it just didn't reach clinical significance. I think the reason for that is these patients are very, very complicated. And I think in our clinic, when we evaluate them, we probably evaluate one aspect of it, but they may be having other aspects to their health, which are probably not optimized by this action plan. So I don't have.
Yeah, when you're talking about patient-centered care, though, there seems to be a disconnect here.
Yes. And I think the other problem with these studies is, with any COPD study, is how do you define, how patient selection, I think, is the main thing. I think in our clinics, we know our patients, we have a relationship with them, and we are able to identify who will benefit from what and who will react to what in which way. But I think in the studies, they don't have the luxury of doing that. So they sort of have a certain inclusion criteria, and they include all COPD patients, and all COPD patients are not the same. They are morphologically not the same. Their phenotypes are different. Their attitude towards their diseases are different. And I think I feel that's one of the reasons why these studies are not able to replicate what we see in real life. So if you,
Thank you. Yeah, that's a very good answer.
Yeah. So the next question is from, thank you so much for the question. That was a very, very good question. And Dr. Watt asks, from your experience, what % of COPD exacerbations can be handled without administration of antibiotics? So that's a very interesting question. So the more and more we are understanding about the phenotyping of patients, we're understanding there is definitely one group of patients who benefit from steroids and inhaled corticosteroid. And there is another group of patients who may not be a steroid responsive patient. So I can give you examples of two phenotypes of patients. So there is one phenotype of COPD patients who have a high eosinophil count. If you go look at the trend of the eosinophil counts, you'll see every time they have an exacerbation, they actually have eosinophilia. Then they'll have some features of asthma, like rhinorrhea, allergies, and things like that. So though they'll be smokers, they'll have emphysema, they'll have all that. But they'll also have some of these aspects: high eosinophil count, some features of asthma like eczema or extrapulmonary allergic symptoms. Then they'll definitely have a seasonal variation in their presentation. They'll have a particular season where they're having more exacerbation. And also, if you look at their PFTs, they can have a significant bronchodilator reversibility. So these are some of the aspects in the phenotype, which tells me this is probably somebody who will be steroid responsive. On the other hand, the patients who are the other phenotype is the patients who have bronchiectasis in their CAT scan, who are more of the chronic bronchitis phenotype, who are like producing a lot of yellow sputum, and they always say, whenever I have an exacerbation, the color of my sputum changes. And that is the group, and their eosinophil count is not usually elevated. And that is the group which is usually responsive to antibiotics. And this is just based on physiological explanation of diseases, right? But there's no evidence for these phenotypes yet. There is some evidence that we can use eosinophil as a marker for making some treatment decisions, like whether to give them inhaled corticosteroid or not, whether we can take them off inhaled corticosteroid if they're doing really well. For those decisions, I think there is some evidence we can use the eosinophil count. Otherwise, there's no hard evidence to use it. What I do is, when I phenotype a patient, let's say I feel that this is an asthma, COPD, or a eosinophil driven inflammation, I try to do prednisone without antibiotic during one of their mild exacerbations and see how they respond. And sometimes you can even ask the patients will tell you, you know what, I don't care about everything else. I just need the prednisone. The prednisone is magic. It just makes me feel so good whenever I have a bad attack. There are some patients who like the azithromycin a lot. So I think you might have to trial one without the other to figure out who will really benefit. But in my mind, these are the two phenotypes. This is how I divide them to determine whether they need one or the other. Does that answer your question, Dr. Ward?
Yes, thank you so much. I think we have
And
time.
I don't know the percent. I don't know the exact percent of
No, I
patients
think that the clarification about the eosinophilic phenotypes is very interesting. I think we have time for maybe one more question before we break.
Okay, so Karen Casper asks, the Vermont asthma program has worked with several provider teams partners to increase the rate of up-to-date asthma action plans on file at schools for children with asthma. While rates have increased over time in the past decade, what are your thoughts about further improving those rate? And are there adjustments in how the care team, including school nurses, engage? So whatever the asthma action plan impact on outcomes which I showed is only for adults. So it's not for children. In children, we definitely know the asthma action plan is very, very helpful. In terms of increase, I think one important thing is to, now that we have healthcare information systems, is to have hard stops on our navigators, the clinic navigators, or best care advisories in our clinic navigators, to make sure that every time that we see the patient, we are reminded whether the patient has an action plan or not. I think that's one way we can use technology to improve creating action plans for all patients.
So this is the end of the formal part of the presentation for those who are not in the collaborative, but I think we're going to transition here now into the next half hour with Ram and our collaborative participants. So a fond farewell to those that are leaving us at this point. And I'm going to turn it over to the collaborative leadership to run the next half hour. I'll stay on the call, but I think Adrian, are you going to be helping with that?